Thank you, Dinesh, for kind words. Now, having understood the basics of fluorescent angiography, let's now move to the clinical condition. We start with venous occlusions. The venous occlusion can have a various clinical presentation from minimal macular branch retinal vein occlusion to central retinal vein occlusion. And in all the cases, to understand what is happening at a physiological level, you need to do an angiogram as a basic investigation. So what do we want to look at this? The basic thing is we want to look for the leakages, that is either because of a new vessels like this or extent of non-perfusion, that is the area because of blockage, the area which will result into ischemia leading to development of new vessels like this. Or to understand a fall in the vision which can be because of a macular edema or a macular ischemia as noted over here. So initial phase when you see an angiogram, initial immediate presentation would be a blocked fluorescence because of the presence of the blood droplets on the surface of retina, that is pre-retinal hemorrhage, and a delayed filling and emptying of the veins. As we have already been told, it usually in 20 seconds AV circulation time would be over, but here it would be further delayed. In a later phase, you might note the development of new vascular response in the form of microaneurysms or development of new vessels. Now coming to the very basic macular tributary vein occlusion, it's a small segment, involvement is usually there, and usually most of the cases do not show much of a visual loss. But angiograms are done whenever there is a loss of vision and if we are suspecting an edema, because a small ischemic area, you can tell the patient that your prognosis is going to be slightly better. Very rarely, an impending venous branch retinal vein occlusion can be picked up by a laminar flow, and usually you will be seeing that the veins occlude at AV cross junction, and this is a classic example. In a branch retinal vein occlusion, what happens is in an initial phase there will be a delayed filling of occluded retinal vein. You would see a capillary non-perfusion areas, and there would be development of following it. There would be development of new vessels either on the disc or elsewhere. Based on an angiogram, you can call a branch retinal vein occlusion as a perfused branch retinal vein occlusion where the capillary closure area is less than 5 disc areas. And this branch retinal vein occlusion is unlikely to develop new vascularizations. And so the risk of neovascular glaucoma and vitreous hemorrhage is less likely. While with a severe, that is a non-perfused BRVO, where the ischemic areas are more than 5 disc diameter or more than 10 disc diameter, these are for sure going to develop new vascularization, and they warrant either an anti-VEGF or a lasers depending on your belief of treatment. So you see a classic fresh branch retinal vein occlusion. Because of the hemorrhages, you see a blocked fluorescence over here. These are the soft exudates, and these are the areas of capillary dropout. So this is a ischemic branch retinal vein occlusion. And if not treated, you will see the development of new vascularization tufts like this eventually, or such a big, almost like a sickle fan-like appearance of a new vascularization elsewhere. Vasculitis can also lead to branch retinal vein occlusion, and this slide has been put. It has a similar angiographic presentation, but here, besides the role of lasers and anti-VEGF, there is a role of steroids which we should not forget. The other presentation of a branch retinal vein occlusion is when it involves a macula. And macula, if it can be either perfused, non-perfused. Like in this case, if you see this area, the vascularity is well maintained and there is a leakage in the late phase. As the capillary foveal avascular zone is well maintained, we would call it a perfused macular edema in a branch retinal vein occlusion, and these patients tend to have a good visual prognosis. As you see in this, there is a total loss of capillary foveal avascular zone. So this will be a non-perfused macular edema, and this, in spite of whatever treatment you do, will carry a bad visual prognosis. And most of the times you would see a mixed response where you will be having a bit of a perfusion and some areas of ischemia. The next extension of a retinal vein occlusion is a hemispheric retinal vein occlusion where more than two retinal vein, branch retinal vein occlusion in the same quadrants are involved. And here again the angiographic pictures we are going to expect is in the form of a blocked fluorescence and sometimes you might see a capillary non-perfusion area, and these are the patients who are more likely to develop neovascularization. Now moving to the central retinal vein occlusion. Here, as you see, in a non-ischemic CRVO, or what we used to call in a older literature impending CRVO, there will be a marked delay in the arteriovenous transit time. There will be masking by retinal hemorrhages, and this is a classic case where you see on an angiogram, you do not see any capillary dropout. And this was done immediately following a central retinal vein occlusion. But let me remind here, the first angiogram in a central retinal vein occlusion or a BRVO will not be the final angiogram. In these cases, as we are aware, 15% of non-ischemic CRVOs get converted in 4 months into ischemic CRVOs, and thereby the role of repeat angiogram. As you see in this particular patient, we had done a fresh angiogram about 1 or 2 weeks following an episode, and he had almost normal angiogram, so we didn't treat him anyway. And 8 weeks down the line, he had a full-blown ischemic CRVO, and that is the role of repeat CRVO, repeat angiograms in cases of central retinal vein occlusion. And as you see, depending on the involvement of a foveal avascular zone, you can have a ischemic macula, and if there is an involvement of foveal avascular zone, the prognosis tends to be bad. So to conclude, angiogram is an essential investigation in the management of branch retinal vein occlusion or central retinal vein occlusion, or be it even a small macular branch retinal vein occlusion. It not only helps you in diagnosing the condition, but it also helps you in managing therapeutic. It has a therapeutic implication, as well as it can prognosticate whether the patient is going to behave well or not. And most importantly, let's not forget the role of repeat angiograms after 6 to 8 weeks, especially in perfused BRVOs and non-ischemic CRVOs. Thank you.